When most of us hear the words sleep apnea, what comes to mind? Probably snoring, right? A blocked airway, some kind of physical problem. But what if I told you there's a type of apnea that has nothing to do with a blockage? What if the problem starts in the brain itself? So let's just tackle the big question right up front. When you stop breathing in your sleep, is it always a blockage? The answer, and this might surprise you, is a definite no. And understanding why that is opens up this whole other world, a completely different kind of sleep disorder. Okay, let's break it down. It's like a tale of two apneas. With the one we all know, obstructive sleep apnea, the brain is screaming, breathe! The signal is on, the body is making an effort, but the airway is physically blocked. It's like a traffic jam. Now look at central sleep apnea. The airway is wide open, the road is clear, but the brain, it's gone quiet. The signal to breathe has just switched off. No signal means zero effort. It's a totally different ballgame.
So yeah, this is fundamentally different from what we usually think of. We're not talking about a plumbing issue here. This is a problem with the command center. The pipes are perfectly clear, but mission control has just gone offline.
So to put an official label on it, central sleep apnea is when you repeatedly stop breathing, not because of a blockage, but simply because the brain fails to send that crucial signal. And the absolute defining feature, the thing you have to remember, is this: a total absence of effort. The body isn't even trying to take a breath.
To really get what's going haywire in CSA, we first have to appreciate how it's all supposed to work. So let's take a little peek under the hood at the brain's breathing command system, the body's own amazing automatic pilot. Normally, it's a beautiful, elegant system. You've got this control center in your brainstem just ticking away like a clock. It's constantly getting updates from these tiny sensors all over your body that are measuring gas levels. And here's the kicker for a lot of people. The main thing that tells you to take a breath isn't a lack of oxygen. Nope, it's the level of carbon dioxide, or CO2, building up.
But in central sleep apnea, that elegant autopilot system glitches. The whole stable feedback loop just breaks down. The brain's control system becomes unstable, CO2 levels start bouncing all over the place, and then the signal to breathe just temporarily shuts off. So that leads us to the critical question, right? Why? Why does the signal just stop? What are the culprits behind this neurological glitch? Well, it turns out there's a lineup of usual suspects. Sometimes, honestly, we just don't know the cause. We call that idiopathic. But more often, it's tied to something else. It can be linked to serious things like heart failure or stroke. It can even be a side effect of certain drugs, especially opioids, which are well known for suppressing the body's natural drive to breathe. Now let's zoom in on one really fascinating subtype called Cheyne-Stokes respiration. You see this specific pattern a lot in patients with congestive heart failure. And here's why. Because their circulation is slow, the message about CO2 levels takes too long to get from the body back to the brain. The brain gets this delayed report, it overcorrects, and the whole system gets thrown into this wild, unstable cycle. And the pattern it creates is this very distinct wave. Breathing gets deeper and faster and bigger. Then it starts to fade away, becoming shallower and slower, until finally, there's just silence. A complete central apnea. And then the whole cycle starts all over again. Okay, so with all these different causes and these strange patterns, how do doctors actually identify this glitch? Let's look at the clues that lead to a diagnosis. What's really interesting is the clues come from two different perspectives. The person who has it, they might just complain about feeling exhausted all the time, having really choppy sleep, or waking up a lot. But their bed partner, they might see something much more specific and, frankly, more alarming: those long, silent periods with no breathing at all. Ultimately, the diagnosis has to be confirmed with an overnight sleep study. It's called a polysomnography. This is where they hook up all the sensors and can literally see it in the data. Airflow stops, but the belts measuring the chest and abdomen movement show nothing, no effort. That's the smoking gun right there. So if you remember one single thing from all of this, let it be this. Central sleep apnea is a disorder of control, not obstruction. It's a brain issue, not a throat issue. Okay, so we've identified the glitch in the brain's command system. The obvious next question is, how do you fix it? How do you go about recalibrating the body's autopilot? Well, the treatment approach usually comes in steps. First, and this is the most important one, you have to treat the underlying cause. So that means getting heart failure managed better or addressing the medications that might be causing it. If that isn't enough, you might use positive airway pressure like a CPAP or a BiPAP to help stabilize breathing. And then for the really complex cases, there's an advanced therapy called adaptive servoventilation or ASV, which is basically a smart machine that provides dynamic breathing support.
But, and this is a huge but, there is a massive critical warning that comes with that advanced therapy. This is a major takeaway. For a specific group of patients with a certain type of heart failure, ASV is actually contraindicated. It can be harmful. It's a vital piece of information for any clinician to know.
And that leaves us with this final, kind of profound thought. We all just assume that when we fall asleep, our body is going to take over and keep breathing. But as we've just seen, that silent, life-sustaining rhythm is not automatic for everyone. And it's a powerful reminder of just how complex and sometimes how fragile the brain's control over our most vital functions can be.